Morning, ladies and gentlemen. For today's CPC, we have a very interesting case, a 3-year-old baby, 3-day-old baby, who has a very interesting problem which was diagnosed.
Cardiac mass which was detected, and she was referred to PGI at 33 weeks of gestation with that cardiac mass. Her first ultrasound at 14 weeks of gestation did not reveal any congenital malformation. However, at 28 weeks, the ultrasound showed left lung was echogenic, query collapsed lung with a small pericardial effusion. And the fetal echo at that stage showed left AV valve, which appeared thickened, and there was a moderate pericardial effusion. At 34 weeks, when the ultrasound was repeated at PGI, there was a large echogenic mass in left ventricle measuring 4.2 into 3.5 centimeter, and it was thought to be a cardiac rhabdomyoma, and there was pericardial effusion. The baby was born by normal vaginal delivery, had weak cry at birth, required bag and mask ventilation for 60 seconds. This baby was a late preterm neonate, delivered at 35 plus 6 weeks of gestation. Birth weight was 2651 grams, which was between 10 to 50th centile, and Apgar scores were 6 and 8 and 1 and 5 minutes. There was history of leaking PV in mother 18 hours prior to delivery. In the family history, this was a non-consanguineous marriage, and there was no history of similar illness, seizures, or death in the family. Parents had no skin lesions or seizure disorder as per the history. Examination and course in the hospital showed that the baby had significant respiratory distress starting soon after birth, required respiratory support in the labor room, and the baby needed intubation in the labor room, and the baby was shifted to NICU at 12 hours of life. There, in the NICU, baby was started on mechanical ventilation. The skin examination showed hypopigmented macules on the left arm. Baby continued to have worsening respiratory distress, requiring 100% oxygen. Hence, the baby was put on high-frequency ventilation at 16 hours of life. And in view of high ventilatory settings and bilateral whiteout in the first X-ray, 1 dose of surfactant was given at 18 hours of life, thinking that it could be a primary or a secondary surfactant deficiency. However, there was only transient improvement, and after that, baby again deteriorated. So, in view of the echo findings of pulmonary hypertension and persistent hypoxemia, injection sildenafil was also started. Baby also developed cardiogenic shock at 10 hours of life, for which baby required dopamine, dobutamine, and later on adrenaline. High settings of ventilation and nearly 100% oxygen continued, and in view of still persistent whiteout X-rays, another dose was attempted at 63 hours of life, but with that the baby did not improve. Injection meropenem was given in view of prolonged rupture of membrane and respiratory distress. This case was reviewed by cardiovascular surgeon, but no surgery was planned. Oral everolimus was started on day 1 of life, suspecting rhabdomyoma. Postnatal chest ultrasound showed a pericardial effusion. However, there was no pleural effusion, and kidney, ureter, and bladder ultrasounds was normal. Now, may I invite Dr. Sanjeev to show us the echo findings?
So, this is the subcostal view. This is the effusion there. There is a heart. There is the effusion. You can see the mass. Mass which is arising from the ventricle clearly. So, this is the right atrium, right ventricle, left atrium, left ventricle. You can see the mass involving almost whole of the LV apex, more than 50% of the LV, and you can see the septal part of the RV myocardium, which is also involved with the mass. So this is the RV systolic pressure measured with the help of TRZ. Is about 34 plus mean right atrial pressure. Mind you, the baby was on high mechanical ventilation, high settings, and multiple inotropes when the study was done. This is to show that there was no right ventricular outflow tract obstruction. That's the main pulmonary artery, RP, LP, free from the mass leakage. So this is the duct showing right to left. This is the arch, that is the MPA, that is the LPA, that is the duct. So stating that PA pressure was suprasystem. And this is the left atrium, left ventricle showing severe mitral regurgitation, that is the left SVC in this case. So it is moderate mitral regurgitation, severe PH, PDH hinting right to left, no outflow tract obstruction, pulmonary wise or systemic wise, mild TR, severe ventricular dysfunction. I can see in 4-chamber view, that is the right ventricle, right atrium, left ventricle. The mass is significantly involved in the left ventricle, also part of right. The largest measure was 4.5 to 4.3 cm. With this, I thought it's multiple mass lesions in LV and RV. Appearance were clearly consistent with rhabdomyoma in the newborn. No inflow, outflow tract obstruction or valvular dysfunction as such. Severe LV dysfunction, moderate right ventricular dysfunction, moderate mitral regurgitation, high pressure tricuspid regurgitation of mild variant, severe PH, duct shunting.
Thank you, Dr. Sanjeev. May I now invite Dr. Arun Sharma from Radiology to show us the X-rays.
These are the serial X-rays of the patient. The initial X-ray show classical white-out bilateral lungs, which could be secondary to neonatal respiratory distress syndrome or airline disease. On subsequent X-rays, there is improvement with the aeration we can see in the peripheral portion of the bilateral lung. However, on the terminal X-ray, there is a deterioration with asymmetric consolidation in right lung secondary to sepsis. Thank you.
Thank you, Dr. Arun. The other investigations in the child, the hemogram was normal and LFT, RFT were also normal. ECG on day 1 showed a normal sinus rhythm. There were multiple blood gases, both arterial and capillary blood gases. All arterial blood gases showed a severe hypoxia. In all blood gases, there were some CO2 detentions in most of the blood gases. So hence the blood gases showed a mostly respiratory acidosis with severe hypoxemia, and sometimes there were metabolic as well as mixed acidosis also. The whole exome sequencing which was sent after death of this baby, which we received later, showed a pathogenic variant in the tuberous sclerosis complex 2. So pre-terminal events, baby was continued on high frequency ventilation with 100% oxygen, 3 inotropes along with injection sildenafil. In view of this worsening respiratory status, and again there was some whiteout, so another dose of surfactant was tried at 63 hours of life. However, the baby required 2 CPRs at that time. Baby also developed ventricular tachycardia, given shock twice, and had 2 cardiac arrests at 64 and 65 hours of life and could not be revived. So declared dead at the age of 65 hours. So the unit's final diagnosis was fetal cardiac tumor, most likely rhabdomyoma with underlying query tuberous sclerosis, with pulmonary hypertension, with cardiogenic shock, with query primary or secondary surfactant deficiency. And the cause of death was assigned to cardiogenic shock and persistent pulmonary hypertension. So in the database, we have antenatally diagnosed cardiac mass thought to be rhabdomyoma and respiratory distress soon after birth. On examination, there was significant respiratory distress requiring ventilation. There was a hypopigmented macule on left upper arm. There was cardiogenic shock, and the echo and X-ray have been explained by Dr. Sanjeev and Dr. Arun. So this was the hypopigmented. This was the hypopigmented patch you can see here on the left arm. So the provisional diagnosis was cardiac rhabdomyoma with underlying tuberous sclerosis, severe LV and RV dysfunction, right to left shunt, pulmonary hypertension, query pulmonary edema with query surfactant deficiency and cardiogenic shock. So the cardiac tumors are overall very rare in the fetus. It could be primary or metastatic. Metastatics are again extremely rare, which could be arising from the neuroblastoma or leukemia. In the primary tumors, you have benign and malignant, and this is the distribution of fetal and neonatal cardiac tumors. You can see here that the fetal tumors mostly are the rhabdomyomas, though fibroma and teratoma also could occur. In the feto-neonatal variety, again the rhabdomyoma is the commonest tumor which has been described in the literature. So the fetal primary cardiac tumors in the perinatal period are rare, and it is the incidence of only 0.14% in the antenatal ultrasounds reportedly. They are mostly benign 90%, though 10% could be malignant, and commonest is the rhabdomyoma, which constitutes about 90% of these fetal tumors. Left ventricle is more often involved than the right, and other sites also could be atrial or IVS or even the valves. So these rhabdomyomas are actually hematomas, because these are the normal tissues which are overgrown. So these are sometimes like they are not called tumors even, they are more like hematomas. So they appear in the ultrasound by 20 to 30 weeks of gestation. Spontaneous regression starts after 32 weeks of gestation, and 75 to 80% cases have spontaneous regression. And they regress by any time between 2 even up to 6 years also it can take for the spontaneous regression. And this regression has no relationship with the tumor size, location, or numbers. There are various cardiac complications described with these tumors, and predominantly the arrhythmias, outflow obstructions, we could be having heart failure, hydrops, which can finally lead to the intrauterine death. And these complications depend on the site size and how invasive the tumor is. Surgical removal is required for severe obstruction or hemodynamic instability, though surgery is very difficult if it is multiple or infiltrative in nature or giant in size. So untreated symptomatic cases have a very high mortality up to 80%, 78%, but if the case is well managed, some literature have reported even the 80% survival also. So this rhabdomyoma has a very close association with the tuberous sclerosis complex underlying, and this could be present in 50 to 90% cases of cardiac rhabdomyomas. And cardiac rhabdomyoma could be the earliest sign of tuberous sclerosis in the fetus. Due to long-term complication, it has a poor prognosis, and if there are multiple rhabdomyomas, then more than 93% association with TSC. However, single rhabdomyomas also has a 71% association. In tuberous sclerosis, there are many series available in which it shows that many other organs are involved, predominantly brain, in which cortical and subependymal tubers you can see, or subependymal giant cell astrocytoma can be seen. In our case, we could not do any brain imaging. Baby was too sick for any MRI. Other than brain, you can have lesions in the kidneys with multiple cysts, angiomyolipoma, angiofibroma. Eyes, skin also can be affected, and many times there is an associated abnormalities in the heart like Epstein, tetralogy of Fallot, or hypoplastic left heart syndrome. Coming to the genetics of tuberous sclerosis, two genes have been identified: TSC1, which encodes the protein hamartin, and TSC2, which encodes protein tuberin. In our case, it was TSC2 which was positive. These TSC proteins are involved in regulation of cell cycles and the normal development of brain and cardiomyocyte differentiation through the mammalian target of dapamycin pathway, through the mTOR pathway. So some subsets of TSC2 also may have a polycystic kidney disease because both are located on the same chromosome 16. The disease is basically 60% cases. These are sporadic mutations in these two genes, and it could be familial in 40% cases, and if so, then it has an autosomal dominant inheritance. Surgical treatment is indicated if there is a severe hemodynamic instability or arrhythmias are there which are associated with significant mortality and morbidity. Non-surgical treatment, the mTOR inhibitors have been tried in symptomatic and inoperable cases. These are in the case reports format only, and in 90% cases, the size reduction has been reported. This drug has been approved by FDA for various immunosuppressive and anti-proliferative agents. And the dose has been a bit variable, and long treatment is required to show the reduction in size. The poor prognostic factors are if there is early gestational age at diagnosis, if there is a preterm delivery, a very big tumor size of more than 2 to 4 centimeter, or if it is associated with hydrops and arrhythmias. So the other tumors which can present like this are the benign tumors like fibroma, hemangioma, myxoma, teratoma. Again, these are very rare. Malignant could be rhabdomyosarcoma, fibrosarcoma, or pericardial sarcoma. Thrombus, generally it occurs in the atria, and there is a history of central venous catheter or in cases of congenital heart disease, but this was detected in utero only, so this possibility we are not keeping. And there is another entity described as oncocytic cardiomyopathy, so some atrial nodules can be seen in this. So basically how you differentiate antenatally is that these tumors, the other benign tumors, have different locations and their echogenicities are different, and some have spontaneous regression like hemangioma, other tumors do not regress. So rhabdomyomas are classically multifocal and homogeneously hyperechoic, though it could be unifocal also. So we had chest X-ray which was bilateral whiteout, already told by Dr. Arun Sharma, and we attribute this to the cardiomegaly, pulmonary edema, query surfactant deficiency, pericardial effusion. There was no pleural effusion in ultrasound as well as in X-ray. Costophrenic angles were clear. Respiratory distress was probably due to pulmonary edema due to biventricular failure. There may be some underlying lung collapse and surfactant deficiency. Cardiogenic shock is ascribed to the severe biventricular dysfunction, and SBT, which the baby developed pre-terminally. And the echo findings, other than cardiomegaly and pericardial effusion, what we found could be obstruction, hypokinesia, and arrhythmia. So our final diagnosis is multiple cardiac rhabdomyomas with underlying tuberous sclerosis. Mutation is TSC2 gene. Autopsy probably will show other organ involvements, which we could not get it done. The brain basically. Cause of death is biventricular dysfunction, shock, arrhythmia, and severe hypoxemic respiratory failure. And our future plan is to call the parents to do the parental screening by genetic, to do their genetic tests, to do their ultrasound kidneys, their systemic examination and eye checkup, and prenatal diagnosis should be offered in the next.
So this is a very interesting case, neonatal tuberous sclerosis, and I think I've seen this case for the first time in my career of 32 years in this department, and I don't think it has ever been presented here. We've seen older cases of tuberous sclerosis presenting with multifocal angiomyolipoma. I mean, there were cases of kidney tumors which came to us, and they were multifocal epithelioid angiomyolipomas, and we went back to the clinician saying that please look for tuberous sclerosis, and in 2 of those cases they did find tuberous sclerosis. So they were in little older children. In fact, they found tumors, they found angiofibromas and things like that in them. But neonatal tuberous sclerosis, this is, I think, the first autopsy we've done in our department. So, so this was, as said, day 3 child for the newcomers who just who came a bit late. Born to a primary grammida, and the baby weighed 28.11 grams. There was polyhydramnios in the antenatal period, and she was born at 32 weeks. Okay, sorry. Born at 32 weeks gestation. APGAR was 6 and 8, and antenatally diagnosed as a case of multifocal rhabdomyoma. And no family history, respiratory distress at birth. There was this patch present on the left arm, and she was started on mTOR inhibitors. Surfactant was given twice, but the child succumbed, and a complete autopsy was performed. The pericardial cavity revealed 10 ml of hemorrhagic fluid. Now this is the heart-lung complex. Now this is the abnormal looking heart. The 2 lungs here, this is the larynx, and this is the trachea. You can see the cartilage rings here, right? Now, if you see, the heart is very abnormal in shape. It is elongated, and the lower end of it is whitish in color. So let's go further. This is again the anterior aspect, showing the elongated heart with this whitish component at the lower end, at the apical end. And this is the posterior aspect. Now, we could not open the heart by the inflow-outflow track, the track technique, and hence we started giving cuts, because this cut was already given by the prosector. So we started giving cuts from the lower end upwards. And that's how we went up in this case. And you can appreciate this huge tumor here, which is creamish in color. And we went up. This is at the root of the heart, wherein you can see that the tumor is in the left ventricle, and this is the right ventricle, which can be appreciated here. And again, this is the anterior aspect, which shows the pulmonary trunk, and this is the aorta, which is coming from beneath it. And you can see these vessels, the brachiocephalic and the common carotid and the left subclavian. And this is the right side of the heart, this is the left side of the heart. But it is so distorted that this is actually the right ventricle. Now, further cut sections, this is the tumor, this is the main tumor, measuring about 5 into 4, 5 cross 4 cross 3. And it is creamish in color. There are no areas of hemorrhage, necrosis, or any calcification that can be seen here. And these are the further serial slices from the apex till the upper end. Now, as you go up, you see that this is in the right, it is in the left ventricle. But then this is the interventricular septa. And you can see smaller nodules present in the septa itself, and you can also see these whitish areas present in the right ventricle. So coming to under the microscope, so this is the myocardium here, the endocardium is here, and then you see this tumor. which is a classical rhabdomyoma, no doubt about it. So at a closer look, you see these large, huge polygonal cells actually with a clear cytoplasm. Now this, you can see the size of these cells, and they have an eccentric nucleus. And very importantly, basically these are actually full of glycogen, but because of the fact that it is formalin fixed, the glycogen has been depleted out, dissolved out. Now, this is at a closer look, and the very characteristic spider cell. This is the spider cell, a diagnostic pathognomic of a rhabdomyoma. They were visible in plenty, and you see these, these laminations that can be seen going from the nucleus right till the cell membrane. So this is the classical cell that we get to see in rhabdomyomas. This is a PA stain, which is negative because the glycogen has been dissolved out. And large areas of calcification were noted, although not grossly, but microscopically. Then, multiple sections were studied from the other areas of the heart, and what we could see was that you could see these microscopic rhabdomyomas. So you could see the muscle, the striated muscle getting converted into a small, tiny rhabdomyoma. So this is what are the tiny, it is actually a hematoma, as what Dr. Kanya said. So these, the striated muscle gets converted into these larger cells with abundant clear cytoplasm, and with typical these spider cells here. So this is the classic spider cell that we get to see here. Multifocal. So this is just to show you the multifocality of the tumor. You can see these tiny tumors all over in the myocardium, both right and left ventricle. This is the Mason's trichrome stain. Again, you can see this is just to show you the multifocality that was present in this tumor. More so here. And you can see these very tiny, tumors coming up all over the place, like here. So this is just the striated muscle getting converted into a small, tiny rhabdomyoma. Now, the striated muscle was, kinked. The cardiac muscle was totally kinked, as you see here. And even in the normal-looking, absolutely normal-looking cardiac muscle, we could appreciate some sclerosis and conversion into these rhabdomyoma cells, as you see here. So in fact, it was the entire heart which was getting converted into a, rhabdomyoma. So this is a case of a multifocal rhabdomyomas, and this has already been told to you all. And 50% patients with tuberous sclerosis develop cardiac rhabdomyomas, and 50 to 85% children with cardiac rhabdomyomas demonstrate clinical and radiologic evidence of tuberous sclerosis. And this is a major criteria for tuberous sclerosis. Now coming to the next organ of interest, which is the brain. Now the brain weighed 378 grams, and external surface showed subarachnoid hemorrhage. And this is one of the coronal slices at the level of the thalamus, and you can see the two ventricles here, lateral ventricles here. And what you see is these protrusions, which are they're small tumors which are protruding from the wall of the lateral ventricle into the lateral ventricle. And these are known as subependymal tumors. At a closer look, some of them are very discrete, some of them are getting confluent, and here, right? So these are subependymal tumors, and here as well, right? And this is another coronal slice at the level of the thalamus, and what you see is that you have, again, you can see the subependymal tumors here, and this is the gray-white junction. Some of the gyri were thin, some of the gyri were thick, so even the gyral pattern was affected. You can see the subarachnoid hemorrhage, and that's about all, and congestion. Now, let's go to the microscopic examination. This is at a low power, and what we see is this is the ependymal lining, this is the lateral ventricle. So we have these subependymal well-circumscribed tumors, which is actually SEGA, which is subependymal giant cell astrocytoma. So this is one of them, this is another one of them. Now these dark blue cells, this is the germinal matrix. Now the germinal matrix, this is a 36-weeker. Germinal matrix by this time should have gone up to the cortex, but it is still here. So this is known as a This is known as germinal, this is the defect, the migration defect, which is very, very extensive in this case. So this is one, this is another SEGA, and this is another one, right? So at a closer look, what we see is in the subependymal giant cell astrocytomas, as they are called, we see these giant cells, which have very abundant, eosinophilic cytoplasm, and you can see them in sheets or as or sweeping in fascicles or as nests, and they, very importantly, they have very, very glassy kind of, very abundant, eosinophilic cytoplasm, and they have nucleolated nuclei. So that's an important thing. They look like gymnostocytes, but they're not gymnostocytes. They are glioneuronal in origin, so they have a wider phenotype. The basic progenitor cell is glioneuronal. So they can be positive for the glial markers, they can be positive for the neuronal markers, or they may not be positive for any one of them, right? Apart from these, we have the dysmorphic neurons which get mixed with these. This is another tuber, another SEGA, which again shows diffuse sheets of these giant cells, and you have these sweeping fascicles as well, and this is another one at a closer look where you see the SEGA is here and you see the germinal matrix. So this is also in the subependymal location at a closer look now. So these are the cells or the giant cells which are glioneuronal in origin. You have abundant cytoplasm. These are the very characteristic cells, eccentric nucleus, vesicular nuclei, and they have nucleoli. Very importantly, they have nucleoli. And many of them have this very glassy cytoplasm, and these are said to be the balloon cells, right? And this is the GFAP. In this case, particular case, this is the ependymal lining. The GFAP was negative, and so were the neuronal markers. We did a couple of neuronal markers too, and they were new and NFP, they were also negative, right? Now, this is the ependymal lining, and all along the ependymal lining, apart from the, the well-circumscribed tumors, we could see these giant cells present all over. In fact, kind of just below the lining, we could see sheets and sheets of these giant cells present all over. And you can see these, the abnormal giant cells. Some of them have this kind of elongated cytoplasm and so on. So what we are dealing with, the first thing is a subependymal giant cell astrocytoma, SEGA. This is another major criteria for tuberous sclerosis. So these are benign, slow-growing tumors, WHO grade 1. They arise in the wall of the lateral ventricle, adjacent to the foramen of Monro over the basal ganglia. And they are seen in about 5 to 15% patients of tuberous sclerosis. They are well circumscribed, can be calcified, and they have these large plump cells which resemble gymnostocytes but are actually not gymnostocytes, right? And these cells are polygonal with abundant glassy cytoplasm, and they can also be spindled as seen in the case. And you can also have these giant cells with ganglionic appearance, what I showed you with eccentric vesicular nucleus showing nucleoli. And so the phenotype is basically ganglioneuronal. Then the other CNS manifestations seen in this case were very, very beautiful. You have these tubers present in the cortical white matter. You see these clusters of glioneuronal cells again. You have some dysmorphic neurons. You have gymnostocyte-like cells, as we saw in the SEGA. And at a closer look, again, you have the glassy cytoplasm, and some of these are actually the dysmorphic neurons. You see these, and some of them are positive for GFAP. And you have these balloon cells, these are called the balloon cells, which are very glassy cytoplasm. These are again, the origin of these cells is glioneuronal. So these are the balloon cells, which are in fact present in the white matter, going right up till the subpile region. So all over in the white matter, we could see these ballooned up cells streaming all over the place. And so these are the balloon cells. And now this is the subpile region. This is the cortex in this case, where everything seems a bit okay. But in other areas, you could see that the subpile region again showed these giant cells, these and dysmorphic neurons. And you could see these giant cells and dysmorphic neurons streaming down the cortex and going into the white matter. So you see the streaming of these giant cells and these dysmorphic neurons going down into the white matter from the subpial region. Now again, this is the subpial region. You can see again these giant cells which are going down into the through the cortical layers. Same here at a higher power. And this is the sulcus here, and again you can see that you have all these glioneuronal cells, these giant cells present in the cortical areas. So this is the high power of these dysmorphic neurons, some balloon cells, some gemistrolite-like cells, some elongated cells, and these striations are very specific for the dysmorphic neurons. So these are the kind of the ganglionic cells with eccentric nucleus and so on. So, and they can assume these kind of shapes as well. So this has a very beautiful neuropathology. So we had cortical dysplasias, which is again major criteria for TSC. We had tumors and cerebral white matter, radial migration defects. And tumors, as I said, had giant cells as seen in SEGA along with dysmorphic neurons. And they can be seen in all the cortical layers and the underlying white matter. And along with it, we can have the balloon cells as what we saw, and the cells are glioneuronal in origin. Coming to the next organ, which is the kidney. Both the kidneys showed fetal lobulations, ureters, and the urinary bladder were normal. But the cut section showed some cystic area here. That was the only area that we could appreciate. Normal glomeruli and tubules. Normal glomeruli, normal tubules. And these cysts were present. Now, this is the minor criteria for tuberous sclerosis. Renal cysts. Apart from the renal cysts, we can get angiomyolipomas and other things, but they were not present in this case. So renal cysts were present. And these cysts were lined by these cuboidal cells. Coming to the lung. Now, the lung was slightly heavy in weight, and cut section showed consolidation, no focal lesion noted. So this is a very low power view of the lung, which shows a very busy lung rather. You have the bronchioles here. At a closer look, this is a bronchus. The cartilage is here, and you can see ulceration of the lining epithelium, and you see this necroinflammatory material inside the lumen, lots of nuclear debris and polymorphs. So there is a bronchopneumonia going on. So this is again larger bronchus, bronchopneumonia. This is a smaller bronchiole, and the alveolar space is full of polymorphs and nuclear debris. So there is a confluent necrotizing pneumonia, which seems to be congenital because this patient had leakage PV since 15 hours before the vaginal delivery. Apart from this, you can see that these acinar arteries are very prominent. Normally, whenever we look at a section of the lung, a neonatal lung, we don't see these so prominently. So this indicates that there is a pulmonary arterial hypertension, persistent pulmonary hypertension. Apart from that, you see these alveolar spaces full of blood hemorrhage. Then this is again the very prominent acinar arteries indicating PPHN, hemorrhage, extensive hemorrhage. And then you have these blobs of meconium. This is not hemorrhage, but these blobs are those of, so this is all meconium aspiration. So this baby also had extensive meconium aspiration. So the liver, pancreas, C-loop of the duodenum, and the section of the spleen. There were no cysts present in the liver. Apart from the microscopic section, there was extensive extramedullary hematopoiesis out of proportion to the period of gestation. You have the megakaryocyte here and the extensive EMH going on in the liver. The spleen was within normal limits. GI tract was within normal limits. Thymus, adrenal, skin was okay. And so these are the major manifestations of tuberous sclerosis, which Kanya has already gone through. And so these are the diagnostic criteria for tuberous sclerosis, and out of which we have 4 major, 1 minor. And the whole genome sequencing done by the Department of Pediatrics showed the pathogenic variant of TSC2. So we have multifocal cardiac rhabdomyomas. Largest was this much, both present in the left and right ventricle. The largest was in the left ventricle, but they were all present all over in the right and left. Pericardial effusion, there was SEGA, there were cortical dysplasia in the form of cortical tumors and migration defects. Chargreen patch was present. Multiple renal cysts were there, and lungs showed meconium aspiration syndrome, congenital bronchopneumonia, hemorrhage and PPHN, EMH in the liver, and stress involution of the thymus. So So this is basically the tuberin and hamartonin. Basically, these are the two proteins formed by these genes. They interact within the cell and form a complex. And mutations of either gene causes disruption of this complex, leading to upregulation of the mTOR pathway, leading to increased proliferation and cell growth. So basically, this is an upregulation of the mTOR pathway, and that's the reason why we require the mTOR inhibitors. They are helpful in such cases. Thank you very much.